everyone, welcome back to my channel Untangle ENT. Since we have studied impedance audiometry in our last video and we have discussed the tympanometry part, now I am here back with another video which is on acoustic reflex, which is also a part of the impedance audiometry. So what is acoustic reflex? It is a part of impedance audiometry. It is an objective test, it is non-invasive, it can also be done in babies, and it is very easy to perform and quick and fast. The principle is a large sound of nearly 70 to 100 decibel causes bilateral contraction of the stapedius muscle, which is detected by tympanometry. Now imagine this as your medullary cavity, which includes the malleus, incus, stapes, and this is the stapedius tendon. Now when a normal sound hits the medullary cavity, as we all seen through the tympanometry, there is reflectance of sound, and through that we get a normal reflectance with a normal compliance of the system and a normal impedance. But when a large sound hits the medullary cavity, there is contraction of the stapedius muscle and there is an increased stiffness of the ossicular chain as well as the medullary cavity, which causes reflectance of the most of the sound and less absorption of the sound, therefore protecting the inner ear from noise-induced hearing loss. And what happens in this is there is contraction of the stapedius, movement of the stapes upwards and outwards, increased stiffness of the ossicular chain and the medullary cavity, which thus causes increased reflectance, decreased compliance, and increased impedance. In gist, the principle thus is large sound reaches the ear, there is contraction of the intratympanic muscle, that is stapedius, which moves the stapes upwards and outwards, causing the stiffening of the ossicular chain, increased impedance of the medullary, and this increased impedance is recorded by the impedance electroacoustic meter. Now let's learn about the pathway of acoustic reflex or the stapedial reflex. This large sound hits the medullary, this gets transmitted to the cochlea, then to the auditory nerve, cranial nerve 8, into the cochlear nucleus. This is the afferent pathway to the superior olivatory complex in the brainstem, where there is efferent crossing over. Now let's see this through a picture. Let's imagine this is your right cochlea, this is your left cochlea. This structure is the brainstem, and this is your right stapes with your stapedius tendons and left stapes with your stapedius tendon. The normal sound comes, it hits the medullary into the cochlea through the hair cells. It goes through the cranial nerve 8 into the cochlear nucleus in the brainstem. Then through the auditory pathway, it goes to superior olivary nucleus. Superior olivary nucleus up to this part is the afferent side. Then crossing over takes place and it goes to the cranial nerve 7 motor nucleus, then to cranial nerve 7, and then to the nerve to stapedius and to the stapedius muscle. So when the large sound hits the medullary cavity, it goes through the cochlea, through the cranial nerve 8 into the cochlear nucleus, through the auditory pathway to the superior olivatory nucleus, then to cranial nerve 7 motor nucleus on both sides to cranial nerve 7 and nerve to stapedius, causing contraction of the stapedius muscle. Now this helps in dampening of the sound, as contraction of the stapedius muscle causes increased stiffness of the ossicular chain in the medullary system with increased impedance and thus dampening of the sound and thus protecting the inner ear from this large sound. You can take it as a note. This is for your pathway, superior olivatory complex in the brainstem. It goes to the efferent crossing over to the ipsilateral ear, motor nucleus 7, nerve to stapedius, and there is increase in the medullary impedance, and therefore AR is tested in the ipsilateral ear. Similarly, efferent crossing over goes to the contralateral ear, motor nucleus 7, nerve to stapedius, medullary increased impedance, and AR is tested in the contralateral ear. Let's learn about the possible disorders. On the afferent side, there can be conductive hearing loss, moderate to severe, or there can be sensorineural hearing loss such as acoustic neuroma or auditory neuropathy, or there can be brainstem lesions like cerebrovascular accidents or multiple sclerosis. Let's learn this through some image. Now suppose there is conductive hearing loss of moderate to severe degree, even there is large sound, it fails to reach the cochlea and does not go through the cranial nerve 8 to the superior olivary nucleus, and therefore the connection is lost in both the side, therefore we get a bilateral absent acoustic reflex. But suppose the hearing loss is on the right side and we give a large sound to the opposite side, the pathway is completely normal and therefore we get an normal acoustic reflex on both the sides. Suppose there is sensorineural hearing loss on the right side, suppose there is auditory neuropathy or acoustic neuroma on the right side, and we give a loud sound on the right side. So the afferent part is disturbed and therefore we get bilateral absent AR and recruitment is positive. We will study about recruitment in some other video. But suppose this hearing loss is on right side, but we are giving a loud sound on the opposite side, that is on left side. In that case, this afferent side and efferent side is completely normal, so we will get normal acoustic reflex. Now the third one, if there is a brainstem lesion such as in cerebrovascular accident in the brainstem, so there is disruption of the afferent side where the lesion is there, again there will be absent bilateral acoustic reflex and recruitment will be present. But again, if we present the loud sound on the opposite side of the brainstem lesion, everything will be normal. Now let's see what are the possible disorders in the efferent side. There can be cranial nerve 7 nucleus lesion at the brainstem, cranial nerve 7 palsy near to the nerve to stapedius, or we can see in Ramsay-Hunt syndrome. There can be disease of the stapedius muscle as in myasthenia gravis, or there can be some medial lesions on the ipsilateral side such as otosclerosis, ossicular discontinuity, or atelectasis. Now let's see this through the image. Now let's see, suppose there is cranial nerve 7 motor nucleus lesion or a cranial nerve 7 peripheral lesion, and we give a loud sound to the ipsilateral ear, suppose in the right side. The sound travels to the afferent side. It reaches to superior olivatory nucleus, but on the same side, that is on right side, the sound is not further transmitted, but on the opposite side the sound is transmitted through the facial nerve 7. The information is transmitted and the stapedial contraction occurs in the opposite side. Therefore, we get a contralateral acoustic reflex in this, but ipsilateral acoustic reflex is absent. Now let's say another setting. This is very interesting. Suppose there is some stapedius lesion on the right side and we are giving a loud sound on the right side. So the efferent and the afferent pathway is normal, but due to problem in the right stapedius tendon, we are not getting the acoustic reflex on the same side, but we will get the acoustic reflex on the opposite side. But suppose there is stapedius muscle problem in both the sides, such as in myasthenia gravis, both muscles are getting affected. Even if we present loud sound in either ear, we will get an absent acoustic reflex. This is a very much diagnostic point. Now one more thing, suppose there is on right side there are some medullary pathologies such as otosclerosis, ossicular discontinuity, or atelectasis. Again, large sound is given to the right side. So the afferent pathway is normal, efferent pathway is normal, but due to medullary pathologies on the ipsilateral side, we will get an absent AR in the ipsilateral side, but a contralateral side AR will be present. But suppose the pathology is in right side and we are giving a loud sound on the opposite side, then what will happen? Then the AR will be present on the same side and it will be absent on the opposite side. So what are the measuring parameters of acoustic reflex? It is its threshold, latency, amplitude and decay. The acoustic reflex threshold is the minimum intensity required to evoke the reflex. It is 70 decibel in a normal condition. In conductive hearing loss, we have seen the acoustic reflex is absent. For recruitment, it is less than 70 decibel. In sensorineural hearing loss, it is more than 70 decibel, or we get an absent acoustic reflex. In facial nerve palsy, it is an absent acoustic reflex. Acoustic reflex decay is the loss of amplitude of contraction. In normal, it is seen at around 500 or 1000 Hz. For sensorineural hearing loss, the contraction is halved in 3 seconds. And in multiple sclerosis, it is absent acoustic reflex. Now, last but not the least, the uses of acoustic reflex. It helps in elimination of the medullary pathology. It helps to differentiate cochlear and retrocochlear pathology, to diagnose the brainstem pathologies, to rule out malingering, which we will learn later how to rule out malingering with tuning forks and other tests, to identify the level of cranial nerve 7 lesion, whether it is in nucleus or in the peripheral nerve, and objective estimation of the average hearing threshold. Hope you could learn about acoustic reflex, its importance, uses, pathway, and its principle, and you will be able to clinically diagnose as well as answer in your vivas through this video. If you like this video, please like, share, and subscribe to my channel Untangle ENT. Thank you.